Sriranga, interventional cardiologist from Jayadeva Hospital. Today, we'll be speaking about one of the very favorite antiplatelet drugs for all the cardiologists, being the name of Ticagrelor. So, this introduction of Ticagrelor has started a new trend and a new age in the antiplatelet era. So, we have come a long way in the evolution of the antiplatelet therapy. So it is very essential for preventing as well as treating any major cardiovascular disease that's caused by thrombus. So the introduction of the aspirin 1980s, and we have come long way from the ticlopidine, apixaban, and the relevant introduction of clopidogrel 1997, and recent introduction of prasugrel in the year 2009, and 2011 was the year where ticagrelor came into existence, and the off late the latest available drug antiplatelet is the IV cangrelor medication. So speaking about all this, yes, aspirin is the baseline therapy. Along with that, the newer addiction for the dual antiplatelets came in a way. So many other drugs, be it ticlopidine, apixaban, sildenafil, clopidogrel, cilostazol, dipyrimidolol, prasugrel. So having seen all this, so dual antiplatelet as a combination that has been over time is either ecosprin. It is usually ecosprin with ticagrelor. Earlier days, people were happy using it with ecosprin clopidogrel, but over a period of time, uh, it has been found that ecosprin plus ticagrelor in certain situation has been found to be superior compared to ecosprin plus clopidogrel. So, what are the limitations of dual antiplatelet? Traditional antiplatelet therapy with the ecosprin and clopidogrel, it was the cornerstone for the treatment of acute coronary syndrome and the PCI. However, the significant number of atherothrombotic events still used to occur, despite we treating the patients and despite regardless of its benefit. So, prompting the development of newer and more potent antiplatelet agents. This potency has been addressed by the ticagrelor now. So ticagrelor is the first in class oral and reversible P2Y12 inhibitor and antagonist of ADP, which inhibits the platelet activation. So it helps to prevent the coronary and stent thrombosis and reduce the risk of myocardial infarction and stroke in patient with ACS. This has been approved by US in the year 2011, and the standard dose of 90 mg twice daily with less than 100 mg of aspirin if it is combined with aspirin. So, what are the pharmacokinetics and the dynamics of the ticagrelor? So, absorption, it reaches its peak plasma 1.5 hours after oral intake compared to the clopidogrel, which takes up to 6 hours, and it has around one-third bioavailability and with a high plasma protein binding of around approximately 99%, and the elimination T half is around 8 hours, and usually excreted through either feces or renal excretion. So in that case, what it means is liver dysfunction we can easily treat with ticagrelor without any risk. Time to peak effect is around 2 hours. Many clinical trials have come up. The meta-analysis which showed the efficacy and safety of ticagrelor monotherapy in patient undergoing PCI. So the risk ratio was 0.67 when compared to the regular dual antiplatelet therapy, and risk of major cardiovascular event was risk ratio of 0.86 with a p-value of 0.008. That means around 14% relative risk reduction. And the secondary outcome also with the usage of ticagrelor in the PCA, all-cause mortality, the relative risk was 0.8, and which with a significant p-value of 0.03, and the adverse clinical events of 0.8. So Alphys study assessed if ticagrelor is superior to clopidogrel in reducing the periprocedural myocardial necrosis especially in the high risk elective PCI with a high value number of patients of around 2,000. So what the results were, the efficacy outcome at the 48 hours, primary outcome periprocedural and major myocardial injury was similar when it was used with ticagrelor with clopidogrel. However, platelet function substudy when it was done, ticagrelor showed significantly lower platelet reactivity compared to the clinical clopidogrel. So, in patients with diabetes, taking ecosprin along with the ticagrelor in patient with stable ischemic heart disease, not in patients with ACS. So the primary efficacy outcome, what it showed is hazard ratio of around 0.85. That is a relative risk reduction of around 15% with ticagrelor. So placebo showed the cardiovascular death of around 3.3%, wherein ticagrelor showed 3.1%. All-cause mortality was slightly lower side onto the ticagrelor. That is around 5.1% compared to the placebo of around 5.8%. Major bleeding was really little high when compared to the placebo group. So, ticagrelor, when added to aspirin, significantly reduced the CV death, MI, or stroke in patients with, especially with diabetes and with a patient undergoing PCA. So the trials that have evaluated the safety and efficacy and ticagrelor in patients with prior MI, that's more than this thing, 1 year of a prior event, ticagrelor of 90 mg showed a major adverse cardiovascular event of around 7.85%, and 60 mg showed a 3-year MAS of around 7.74%. So measures. So basically, 60 mg of ticagrelor showed little less bleeding risk compared to 90 mg. So ticagrelor significantly reduced the CV death, MI, stroke, but increased major bleeding risk. But 60 mg BD has a lesser tendency of bleeding compared to the 90 mg BD dosage. The Pegasus TIMI 54 trial assessed two ticagrelor doses, that's 90 twice 60 mg BD, and both ticagrelor dose significantly reduced the risk of primary composite outcome, cardiovascular death, and myocardial infarction compared to the placebo. So guidelines and recommendation, ACCH, the American guidelines say that ticagrelor is recommended at a dose of 180 mg orally that can be chewed for a faster action in a patient with the ACI. And the NICE guidelines as well, it says that it could be combined with a lower dose of aspirin for up to 12 months. And ESC guidelines as well say that ticagrelor, irrespective of the preceding P2Y12 regimen, in STEMI patient undergoing invasive management, ticagrelor of 90 mg BD should be started as soon as the diagnosis is made. If only unavailable, clopidogrel can be considered as an alternative. So, what are the take-home messages for today's topic? Is ticagrelor is the first-in-class oral reversible P2Y12 receptor antagonist that inhibits ADP-mediated platelet activation. So, and thus reducing the platelet aggregation and the thrombus formation and the risk of coronary and stent thrombosis. So, clinically, it has been approved for the secondary prevention in the patients with the prior MI, that is 1 year, more than 1 year, and high atherothrombotic risk, as well as in patients with the ACI who have been treated medically, as well as with PC, and are the patients undergoing the CABG. So, all line of treatment, ticagrelor is advocated. Efficacy, it significantly reduces the MACE, CV death, MI, stroke, especially in the high risk population, like that of patients with the diabetes and the prior high risk PTCA. And the risks that we often anticipate is with associated risk of major bleeding when compared to the placebo or other standard therapy, that is clopidogrel. Thank you.